I'm Dr. Kevin Kavanagh from HealthWatch USA and would like to present with you today on the need for the public to embrace public health strategies for COVID-19, along with the detrimental effects of misinformation. Now, needless to say, this presentation is the express opinion of myself and not that of HealthWatch USA. Our ability to effectively confront COVID-19 has been severely hindered by a number of barriers, and these barriers have included the holding of personal rights over the welfare of society, mistrust of science and government agencies, mixed messaging of COVID-19 information, and organized COVID-19 disinformation. So I'd like to talk about the holding of personal rights over the welfare of society. Dr. Hunter McGuire, president of the American Medical Association, stated, "A difficulty in dealing with infectious disease in America was the rooted dislike to the curtailment of the personal liberty of the citizen for the benefit of the people at large." In addition, Dr. McGuire asked the federal government to engage and organize in the fight against epidemics and properly protect its citizens. The telling aspect of this appeal was that it was made in 1893. Unfortunately, things have not changed much in the United States. Another barrier, which I feel is very significant, is the mistrust of science and governmental agencies. There has been, which I can call as nothing else, a war on science. Scientists and scientific studies have been accused of bias and making findings based upon politics and not data. The award-winning author Sean Odo wrote in Scientific America that if anyone could discover the truth of something for him or herself using the tools of science, then no king, no pope, and no wealthy lord was more entitled to govern the people than they were themselves. It was self-evident. Early on, Fox News commentator even called the COVID-19 pandemic a hoax, and misinformation spread from there. One of the most recent examples of misinformation was when the president insinuated that frontline medical providers were overdiagnosing COVID-19 patients to receive money. Examples were given of patients dying of heart disease and cancer who were given COVID-19 causes of death, instead of attributing the death to their underlying conditions. This insinuation occurred at almost the same time that an article was published in the British Medical Journal, which found 1 in 6 hospitalizations were from frontline healthcare workers or their families. Patient-facing healthcare workers were found to have a 3-fold increased risk of hospitalization compared to non-patient-facing healthcare workers. And here are the facts. The increased payment, which is based upon the COVID-19 diagnosis, is applicable only to hospital billing. Hospitals have separate coders for their bills than physicians. Physicians are paid by services rendered. They do not get extra money for diagnosing COVID-19. They report deaths, and deaths are then investigated by the health department. COVID-19 is as much a heart as a lung disease. It can cause a heart attack. And in COVID-19, myocarditis commonly occurs. Myocarditis was seen in 15% of OSU college athletes who had COVID-19 testing. 62% of patients hospitalized with COVID-19 have elevated cardiac enzymes. 20% of hospitalized COVID-19 patients have heart damage when discharged. And COVID-19 also commonly causes hypercoagulability of the blood, and this is the pathological basis of a heart attack. Finally, if one dies of COVID-19 and has cancer, it still counts. Just imagine an airline company giving a news conference after a fatal airline crash which kills 300 people, stating that they were only going to count 200 people as dying from the crash because the rest were old or have cancer. This is unacceptable and unethical. Premature deaths count. There has also been abundant mixed messaging regarding COVID-19, which has resulted in significant barriers to the public accepting public health advice. This mixed messaging has come from both the CDC and FDA, which has led to confusion with the public. Mixed messaging by the FDA has included overstating the efficacy of hydroxychloroquine, remdesivir, and convalescent serum or plasma. Mixed messaging from the CDC has included the use of face masks, aerosolization of SARS-CoV-2, and testing for asymptomatic carriers. So let's talk about hydroxychloroquine. This has been very problematic. The FDA originally gave an emergency use authorization, but then withdrew it due to unfavorable results. There have been 9 randomized controlled trials which have failed to show a benefit. 6 of these have been double-blinded. These trials studied a wide variety of indications in COVID-19 disease, from prophylaxis and its use in mild, moderate, and severe infections. This slide shows 4 of these trials. This slide shows another 4 of these trials. The 9th trial is a randomized controlled trial from the WHO Solidarity Trial, which was conducted by the World Health Organization. Many of these trials were performed in multiple countries. This is definitely not a political issue. A new laboratory study also does not support the use of hydroxychloroquine. An earlier study, which has been widely quoted, reported that hydroxychloroquine inhibited viral entry into cells by 99%. However, this study used green monkey kidney cells. A recent study using human lung cells failed to find a significant effect. The reason? A different enzyme is used for viral entry in human lung cells. Thus, hydroxychloroquine works in monkeys, but not in humans. The Zelenko Protocol is also problematic. This protocol uses a combination of hydroxychloroquine, azithromycin, and zinc. And I can describe this as none other than a toxic mix. As we've previously stated, COVID-19 commonly attacks the heart and causes a myocarditis. Hydroxychloroquine prolongs the heart's QT interval, which can cause dangerous heart arrhythmias, especially in an inflamed heart. Azithromycin also prolongs the heart's QT interval, which can potentiate the chances to develop dangerous heart arrhythmias. So needless to say, this is a toxic mix. I have no idea how anybody came up with this cocktail. Now, remdesivir is another drug which I feel has had its efficacy overstated. There have been high hopes on initial results, but follow-up studies have not been as promising. There have been 2 subsequent studies. One which was published in JAMA Network, which reported better clinical status in only 1 of 2 experimental arms, which described the observed benefit of remdesivir as of uncertain clinical importance. And the WHO Solidarity randomized trial, which found that remdesivir had little or no effect on overall mortality, initiation of ventilation, and duration of hospital stay. The efficacy of convalescent serum or plasma has also been overstated. The FDA has had to walk back their initial reported results. The touted benefit of convalescent serum was only seen in the group of patients with the highest concentration of antibodies and if the patient was not extremely sick. In addition, it had to be given within 3 days of the diagnosis. A randomized controlled study in British Medical Journal also reported that in hospitalized COVID-19 patients, convalescent plasma was not associated with a reduction in progression to severe COVID-19, nor a reduction in all-cause mortality. There have been at least 6 studies which have found that SARS-CoV-2 neutralizing antibodies rapidly drop in the first 1 to 3 months after infection. This is most pronounced in asymptomatic or mildly symptomatic patients. In other words, it's hard to collect antibodies from donors who have their levels rapidly dropping. Thus, there are barriers on both the collection and administration of convalescent plasma, along with suboptimal outcomes. Hopefully, high-quality monoclonal antibodies from Regeneron and Eli Lilly can overcome these barriers. Now, there have also been abundant mixed messaging from the CDC and others regarding the use of masks. On February 29th, the Surgeon General tweeted to the public, "Stop buying masks," that masks were not effective in preventing the general public from catching the virus, and they were needed for healthcare workers. Granted, the United States had a severe mask shortage. At one time, the CDC even recommended that as a last resort, one could wear a bandana. Initially, N95 masks were not recommended for all COVID-19 patient encounters, and risk to the healthcare workers of not wearing an N95 mask was downplayed. The CDC reversed their stance regarding the public wearing masks when it was realized that between 40 to 45% of infections were asymptomatic or pre-symptomatic, and that these carriers caused a substantial amount, possibly up to 50% of the transmissions. Thus, wearing a mask not only protects the wearer, but if the wearer is an unknown carrier, it will help to protect others. Although the CDC advocated for wearing masks, their messaging was not always consistent. At first, they stated parishioners should wear masks at church while singing, but after weeks of negotiation with the White House, they had to walk this back. The CDC then urged masks to be worn at large gatherings such as protests and political events, but because of the mixed messaging, this advice had reduced impact. On April 3rd, there was mixed messaging regarding the use of masks, with President Trump stating, "The CDC is advising the use of non-medical cloth face coverings as a voluntary health measure." On October 20th, 2020, the CDC strongly recommended the wearing of masks on public transportation, including buses, trains, and airplanes. However, the Trump administration has declined to comment on the recommendations or to issue a mandate. And just this week, the CDC stated that evidence shows that masks also help to protect the wearer. Now, there's also been confusion regarding aerosolization. The CDC has changed its guidance multiple times regarding aerosolization of the virus. In other words, is this virus airborne? Aerosolization means the virus can linger and it can float in the air and it can survive for hours. Importantly, it can travel in this state much further than 6 feet. On September 18, 2020, the CDC posted on their website that SARS-CoV-2 could aerosolize with coughing, sneezing, singing, talking, and even with breathing. But then 3 days later, on September 21st, this material was taken down. On October 5th, 2020, information regarding aerosolization of the virus was reposted to the website. The information stated that SARS-CoV-2 can aerosolize and that enclosed spaces are an increased risk, that shouting, singing, and exercising can aerosolize the virus. And finally, adequate ventilation is important to defeat the aerosolization of the virus. This means having abundant PPE, including N95 masks, and upgrading ventilation systems is of utmost importance. In schools, there should be 6 to 8 complete air exchanges per hour, along with sanitization of the air. And of course, you also should be using masks plus social distancing, reduced class sizes, and having the students stay within a small bubble. This is all extremely important. This virus, under certain circumstances, can aerosolize. And I should add, that's why making restaurants where people are talking loudly, and bars, very problematic. Now, the testing of asymptomatic carriers is another very problematic area. There have been extensive mixed messaging from the CDC regarding the testing of asymptomatic carriers. On August 24th, 2020, the CDC stated they no longer recommended testing to detect asymptomatic spread. This caused alarm among many healthcare providers and infectious disease experts, since without testing for asymptomatic carriers, community spread could not be monitored for. And most importantly, asymptomatic carriers were important to detect because they were a major driver of the spread of this virus and of the pandemic. Then on September 18th, the CDC reversed its guidance and again recommended the testing for asymptomatic carriers. Another barrier is organized disinformation. This mixed messaging, which is coming from the federal government, pales in the organized disinformation of consistent misinformation, which is being found on the internet. False information, as I stated, is spreading widely on social media. A study by Carnegie Mellon University found that nearly half of the accounts tweeting about the coronavirus were likely bots. These bots seem to follow the playbooks of propaganda machines of Russian and Chinese governments. This was confirmed by a Reuters report which described a European Union document which detailed how a Russian disinformation campaign was pushing online fake news. The fake news was in English, Spanish, German, and French, making it harder for the EU to communicate its pandemic response. And I can tell you that on HealthWatch USA's website, we have been consistently attacked from trolls. And some of these were based in organizations in France, in Scandinavia, just giving out a plethora of unscientific misinformation, but all having standardized talking points. So I do feel it is highly organized to get our public off track to control this epidemic. In addition, a Cornell University study analyzed 1.1 million articles which contain misinformation and found over a third mentioned President Trump. And President Trump was the only subject mentioned in 10% of the articles. The largest category was miracle cures, which comprised approximately 26 of the articles. And this, for example, would be that hydroxychloroquine might work with COVID-19. And as we can see from 9 randomized controlled trials, this is highly unlikely. At this point, one would want to choose another potential agent in order to get effective treatment. Unfortunately, these campaigns are effective. Here is a recent poll from the IPSOS Group, which is a multinational market research organization with headquarters in France. This was an October 20th, 2020 poll, which was less than 2 weeks before the election. And at that time, 6% of the public still believed a vaccine would be present by Election Day. And needless to say, Election Day came and passed, and no vaccine is present. 19% of the public believed herd immunity can be reached with few additional deaths. And 28% believed hydroxychloroquine is effective. So the public still has large buy-in with hydroxychloroquine. And the danger of that is they'll opt for that drug and take that prophylactically instead of getting the vaccine. Now, examples of misinformation are many, and what I'd like to talk about are the following: that herd immunity will work, children do not get sick, the pandemic is like the flu, masks do not work, only 6% of COVID-19 deaths actually are from COVID-19, cases are up because testing is up. Well, herd immunity is nothing but a false narrative. The virus is too infectious, and herd immunity would take far too long for it to be a viable option. The 1918 Spanish flu took 2 years to abate, 4 years in New York City. COVID-19 has an R0 of 5.7 in an unmitigated pandemic. Now, this means that for every infected person will, on average, transmit the virus to 5.7 others. So it would take over 80% of the population to become immune before herd immunity would start to kick in. It is estimated the United States would lose 1 to 2 million individuals before this would take place. By Thanksgiving, we'll have lost 250,000 individuals in the United States to COVID-19. In addition, immunity probably will not last. Other coronavirus infections give immunity for approximately 1 to 2 years. 6 studies have reported neutralizing antibodies to be falling in COVID-19 patients after just 2 to 3 months, especially in those with mild or asymptomatic infections. One study published in Nature in June of 2020 by Robinani et al. Concluded most convalescent plasma samples obtained 39 days after symptom onset from individuals who recovered from COVID-19 do not contain high levels of neutralizing activity. In another study, published in Nature Medicine in June of 2020 by Long et al., found that in early convalescent phase, that's 8 weeks post-discharge from hospital, 40% of asymptomatic individuals and 12.9% of symptomatic patients became seronegative for IgG antibodies. So the take-home message here is, let's all pray for memory B cells. And the narrative that you can safely achieve herd immunity by sheltering those at risk is false. You cannot shelter all of those at risk since they comprise at least 50% of the adult population, and our households are commonly multi-generational. Remember, obesity is the highest risk comorbidity, and so is being over the age of 65. There are too many individuals, and they would have to shelter too long of a time for herd immunity to be a safe strategy. And finally, herd immunity does not only include humans in the herd, but also cats and dogs. The CDC advises treat your pets the same way as other family members. And as an aside, just last week, there was the release from the Denmark Department of Health, which described an outbreak of SARS-CoV-2 in their mink population. This jumped from a farm animal handler to the mink population and back to, as I've heard, as many as 200 farm handlers. Well, unfortunately, in this transmission of the virus from humans to animals and back to humans, the virus mutated, and those mutations appeared to make it resistant to potential vaccines. So this is bad. The government of Denmark culled or killed 17 million minks. That is an unbelievable number. And for those of you who are coronavirus deniers, if there are any, this should illustrate that one, herd immunity will be impossible to achieve because you also have to deal with animals. And two, how serious this virus is and other countries are taking it when they literally decimated one of their major agricultural businesses in order to control and snuff out a mutation of this virus. It also should illustrate why we need to adopt public health strategies and to quit this disinformation, not wearing masks and not social distancing, because if we continue to spread the virus, it will mutate and we will wind up with an infection that our current vaccines, which are coming on board, won't be effective against. So we need to control this virus. Now, there's also information that children do not get sick. And again, this is misinformation. It is false. As can be seen in this slide using data from a report which is published in Pediatrics, almost 3% of children become severely ill or sick with COVID-19, and 0.5% become critically ill. And granted, deaths are rare, but why we are just focusing on deaths and not long-term disability is really beyond me. These children who become hospitalized and critically ill are at risk for long-term disability from heart and lung disease. This is very common to occur with this virus. Symptoms might initially be absent because they may only present decades later when a patient's pulmonary and lung reserve starts to diminish. And in addition, children can transmit this virus to their caregivers, that of their parents and their grandparents, who are commonly taking care of them at home. So again, it is important to control this infection in children. Now, another false narrative is that COVID-19 is just like the flu, and I'm going to have a number of slides to address this area of misinformation. The 2019 to 2020 flu season has caused 18 million Americans to become infected, 410,000 hospitalized, and 24,000 deaths in the United States. We have already surpassed this with COVID-19 by a factor of 10. Now, of course, deniers will try to convince you that SARS-CoV-2 is not that deadly, citing asymptomatic carriers and silent spread in the community. Now, I'll try to explain this. It is a little difficult. But your chances of dying if you're going out shopping in a crowded retail store, it's a function of you catching the virus, and if you catch the virus, the chances of you dying of the infection. If you increase the number of people defined as being infected by including asymptomatic carriers, you will also decrease the fatality rate of COVID-19. But you also increase the R0 or infectivity of the virus. In other words, more people getting infected. Thus, the number of individuals dying is the same, as are your chances of dying if you venture out into the public. And with long-term immunity having not been substantiated for mild or asymptomatic carriers, this is not a good way to analyze data or to formulate public policy. Now, a much better way of evaluating for deaths from COVID-19 is looking at excess deaths. Excess deaths is an accurate, time-tested method for estimating the lethality of a pandemic. Total deaths in the United States, along with other countries, have been calculated and tracked over decades. They are relatively consistent and can be used to predict and calculate deaths from a pandemic. On August 1st, 2020, there were over 2,000 excess deaths in the United States. And on October 3rd, there were more than 299,000 excess deaths. Excess deaths include both COVID-19 deaths and those from collateral damage, such as non-COVID-19 patients not seeking care and patients not being able to obtain medical care. But they also include lives saved from collateral benefits, such as reduction in other infections from following public health strategies and reductions in deaths from car accidents because fewer individuals are traveling. Overall, excess deaths bolster the argument that we are undercounting, not overcounting, the deaths in this pandemic. And I should add that if in Kentucky or other states, we fill up our ICU beds and our hospital beds with COVID-19 patients, many patients then will not be able to obtain medical care. And when this happens, excess deaths will go up. And I believe these deaths should be counted from COVID-19. They are critical. This will place a huge strain on our healthcare system. And it is a sign that we were not properly prepared for a pandemic when this hit us. Now, the overall fatality rate for COVID-19 in New York City at the beginning of this epidemic was calculated at 1.39%. The fatality rate was found to be comparable to that of the Spanish flu. Thus, COVID-19 is much deadlier than the seasonal flu. And this is supported by its hospital course. Hospital length of stay for COVID-19 is 8.7 days. For influenza-like illness, 5.1 days. For ICU mortality, it's 38% for COVID-19. For influenza-like illness, 13%. Non-ICU mortality, a six-fold difference, with COVID-19 being more lethal, with 10.9% of non-ICU patients dying versus 1.8% for influenza-like illness, and ICU admissions occur in 24% of COVID-19 patients, 17% of influenza-like illness patients. And COVID-19 affects every organ of the body. It directly affects the heart in over 62% of hospitalized patients. And I feel COVID-19 can be compared to polio. Polio has an R0 or infectivity of 5 to 7. COVID-19 has an R0 of 5.7. In polio, 72% of cases are asymptomatic. In COVID-19, there are asymptomatic cases in 40 to 45% of the infections. Severe polio, that which causes paralysis or strokes, occurs in 1% of infections. ICU hospitalizations with COVID-19 occur in 5 to 11% of infections. And if you look at the fatality rate in polio, this is between 0.02 to 0.1% of cases. In COVID-19, 0.5% to 1.5% of teen cases will die of the infection. And I think that one of the best ways of convincing coronavirus deniers is using the statements of President Trump to convince them that COVID-19 is a serious disease. Bob Woodward has released tapes of President Trump's interviews. On February 7th, President Trump stated, "It goes through the air, Bob, the air you just breathed." And that is how it is passed. It is also more deadly than even your strenuous flus. This is more deadly. This is 5% versus 1% and less than 1%. This is deadly stuff. On March 19th, the president stated, "To be honest with you, I wanted always to play it down. I still like playing it down because I do not want to cause a panic." And on October 22nd, 2020, during the second presidential debate, President Trump stated N1H1 was far less lethal than COVID-19. Now, I'd like to talk about disinformation on masks. And believe me, this has been abundant. And the disinformation has stated that masks do not work. However, masks do work. And although social distancing is very important, it is not enough. 6 feet is designated to reduce droplet spread, but coughs and sneezes can spread even further without masks. The mask will protect the wearer, but it will also protect others, especially if the mask wearer is an unknown asymptomatic carrier. Masks will result in an almost 6-fold decrease in transmission to the wearer, and masks will decrease the amount of virus the wearer is exposed to. And this is very important because it's felt that that is an important factor in producing milder disease. In other words, the viral load that you are exposed to on the front end will be related to the severity of COVID-19 that you may develop. Eye protection will produce a 3-fold decrease in transmission, and proper donning and doffing of PPE equipment is especially important. Thus, masks are not nearly enough protection to be relied upon themselves. You should also perform social distancing, and it will also help to protect yourself. The pictures below shows what happens during a cough. The left lower picture demonstrates the use of a mask with little spread of the virus. The picture on the lower right shows that without a mask, viral particles can spread up to 12 feet during a cough. A sneeze can spread viral particles up to 27 feet. There have been 2 recent studies which have found masks to be effective. One found masks to reduce the chance of infection if worn by family members before the onset of symptoms in another family member. And another found that masks help to prevent healthcare workers from becoming infected. And let's not forget about the Missouri hair salon outbreak, which didn't happen. There were two hairstylists which worked at a single hair salon in Missouri. They had 147 clients and 200 to 300 other people inside their salon. The two hair salonists were COVID-19 positive and exposed all of these individuals, or potentially exposed, because all wore masks, and there were no transmissions and there were no additional infections. And this is probably the best demonstration of the effectiveness of masks. Now, there's also been abundant disinformation that only 6% who are counted as COVID-19 deaths actually die of COVID-19. Well, this assumes that everyone with a comorbidity did not die of COVID-19, but that they died of their comorbidity. This is not valid because the deaths were premature. As previously stated, 50% of the adult population in the United States has a COVID-19 comorbidity. Being over the age of 65 or obese has a high risk of severe COVID-19. Unfortunately, in Kentucky, these two comorbidities are all too common. And you will hear the argument that cases are up because testing is up. The premise of this argument is that the increase in cases are seen just because of increased testing. But it is much more likely that when COVID-19 surges, there are more infections and more possible individuals exposed which need to be tested. This graph is from Johns Hopkins and shows the increase in tests in Kentucky. Testing has at least doubled from October to the early November period. In this slide, the graph on the left shows Kentucky's COVID-19 cases in blue and the 7-day case average in brown, along with hospitalizations shown in red. As you can see, there's an increase in cases corresponding to the increase in testing, but hospitalizations rose in red, and because of this, it is unlikely that this increase we're seeing is due to just testing, and it needs to be remembered that hospitalizations will lag cases by about a week. Now, the graph on the right shows deaths in dark blue and the 7-day average in green, along with test positivity rates in purple. As you can see, deaths had two peaks, one in late August and another in late October and November. Deaths are also a lagging indicator which follows hospitalizations by 10 to 14 days. And deaths will lag cases by about 2 to 3 weeks. So when we're still peaking in cases in Kentucky, we haven't even reached our case peak. Our deaths will not peak for another 2 to 3 weeks. And I think it is going to really be, I hate to say this, just horrific. If you look at the data in the United States, just by looking at our cases which are being diagnosed, one would project in 2 and 3 weeks, our deaths will be between 2,500 and 3,000 per day. And this is what's happened during the first wave and during the second wave. It's going to happen during the third wave. It's magical thinking to think that for some reason during the third wave, the same type of characteristics of this infection are not going to occur. Also of concern is that in Kentucky, test positivity rates have also been rising from below 4% in mid-October to over 6% in late October to now when they are greater than 8%. And I should add that in my slides and notes on Monday, I had 7%, but I had to change it. Greater than 8%. We are in a time period of exponential growth. Thus, one can conclude that the rising cases we are seeing in Kentucky are real, since hospitalizations, deaths, and test positivity rates are also rising. This is not an aberration caused by increased testing. Now, I want to talk a little bit about vaccine hesitancy. The public has been very hesitant on taking vaccines in general, especially with rural populations, and especially with the COVID-19 vaccine. 1/3 of the public in general will not take a COVID-19 vaccine even if it is proven safe and effective. 45% of the public are not likely to obtain one if it is only on the market for a few weeks. Now, this is not a political issue. 78% of all surveyed individuals, including 82% of Democrats and 72% of Republicans, feel the vaccine approval process is being driven more by politics than science. And a public survey on vaccine hesitancy was presented at the U.S. Food and Drug Administration's Vaccine and Related Products Advisory Committee, which was held on October 22, 2020. And the following were concerns expressed by the public: that the rapid speed of the vaccine approval process may result in it not being effective or safe. There was a distrust of government and governmental agencies. Respondents wanted recommendations from a well-established, reputable organization without ties to government or industry. There were concerns about political and economic influences, along with trying to get out the vaccine before election, and that there was fear the vaccine would not work. And we all need to remember that, similar to the influenza vaccine, different dosages may need to be given in the elderly, and that data will not be available until much later, until after the trials have ran for approximately 6 months. And there was a concern that the vaccine is being tested on minorities, similar to the Tuskegee experiments, at the benefit of the sheltered upper class. Now, unfortunately, the hesitancy in racial minorities regarding COVID-19 vaccines is very problematic, since they are the highest risk for severe COVID-19. Racial minorities make up the majority of frontline healthcare workers and have the poorest access to healthcare. Native Americans are the highest risk for COVID-19, over 5 times that of non-Hispanic whites. And in Kentucky and southeastern Kentucky, we do have a Native American population. Now, I would like to show you and talk a little bit about how to respond to misinformation. Because believe me, there are abundant, and I've gone through both the talking points and the science and data to refute them. So there are 4 keys in responding to misinformation. The first, you must give a clear statement that the misinformation is not true. Tell the real evidence-based facts. Quote your source, and if able, be able to tell why fake news is not factual. Now we'll do an example here of the Zelenko Protocol, and this is a combination of hydroxychloroquine, azithromycin, and zinc. You need to have a clear statement that the protocol is not an effective treatment for COVID-19, that there have been 9 randomized controlled trials which have not been able to demonstrate hydroxychloroquine's effectiveness. These trials have studied prophylaxis and the use of hydroxychloroquine in mild, moderate, and severe cases, and that these findings have been published in reputable medical journals, including JAMA and the New England Journal of Medicine, and that this protocol is not even safe. The heart is commonly attacked with COVID-19, making cardiac arrhythmias caused by hydroxychloroquine even more dangerous. Azithromycin has the same toxicity and will potentiate the dangers of fatal cardiac arrhythmias. And in the laboratory, hydroxychloroquine works in humans and not monkey kidney cells. And there's the example of masks. A clear statement needs to be given that the misinformation that masks are not effective is not true. A well-constructed and fitted cloth mask is effective in preventing the spread of COVID-19. A mask will decrease the chances of the wearer of getting COVID-19 by almost 6-fold. Masks will also reduce the viral load the wearer is exposed to and thus may cause a milder illness. But if a mask wearer is an unknown asymptomatic carrier, it will also reduce the spread to others. There are abundant studies and recent references listed on the CDC website, along with a number of videos demonstrating how this virus is spread. The public in the United States has a long history of not liking masks and feeling masks are anti-American. This existed long before COVID-19. However, we must adapt and change in order to fight this virus. So with this, I'd like to conclude the presentation and see if you all have any comments. Please put them in the chat box. We have a few extra minutes to address those. In addition, a copy of an updated slide deck can be downloaded from healthwatchusa.org. Just click on the Continuing Education screen button at the top of the page. Thank you very much.